final decision. One more thing is the protection of health. So the patient's health safety is very important and should be protected. So the providers have obligated to always play it safely with the patients and the follow-up care on the patients. And definitely the confidentiality, just like any other procedure. Blood transfusion, blood products transfusion also has to be dealt with it with full confidential. So why we're saying this? Somebody can ask this question. I mean, I thought like transfusion is very simple and very easy. Can transfusion cause harm? Yes, absolutely. A lot of us know these, and there is a long list of transfusion reactions, some which we know, some which we are not sure about, and some which we don't know even. And Dr. Blumberg yesterday, he did talk about some papers showing that lymphoma or leukemia could happen way after transfusion in many years. And that's one of my projects actually I'm working on right now. So what the big deal with cancer patients? Why we are talking about cancer patients in particular? Because cancer patients, according to multiple studies, could reach up to 60% of the anemia. Up to 60% of them have iron deficiency anemia. And that's due to multiple reasons. Could be the nutritional, as the intake, iron deficiency, vitamin deficiency, you name it. Could be due to blood loss. A lot of issues could cause the blood loss, from bleeding to coagulopathy, which a lot of people, they don't pay attention to it sometimes, and chemotherapy, excessive phlebotomy, hemolysis, which could be either auto hemolysis, mechanical hemolysis, or drug or transfusion-induced hemolysis, plus all the other comorbidities, and don't forget TREM, that could also happening because of transfusion. In this study, Heller et al. Did a systemic search for something. Sometimes we think like it's very minor and we don't pay attention to it. But in this systemic search, they looked at the daily blood volume loss from each patient for diagnostic stuff. And they found almost 2,200 studies. 38 of them were included in their study, and 9 of them were interventional studies versus 29 of them were observational studies. And they noticed that up to 377 ml of blood could be wasted just from phlebotomy blood draw. For those who are not familiar very much with the blood banking or the size of the red blood cell, a bagged red blood cell's size or volume is about 320 to 350 ml. So here we're talking about up to more than 1 unit could be lost just because of phlebotomy. Then they show these 9 studies that's included interventional studies. And as you can see here, the cardiac and the surgical patients were lost most of the blood on a daily basis up to above 300 ml. Then they show the observational studies, the 29 studies of observational studies. And as you can see, it's high on, it's like a lot of different ranges between different studies, but the highest were in the general units of the hospitals. More than even the ICUs themselves. And that's a lot. That's reaching up to 100, 120 cc. John Hopkins study, they studied the amount of blood that could be drawn for lab test or wasted as a discard in different ICUs at their hospitals. And they found that an average patient could lose up to 60 ml of blood. 60 ml, multiply this by 5-6 days, that's about 1 unit of red blood cells. So these are the anemias that we are causing by sometimes over-testing, sometimes unnecessary testing, and sometimes you do the test and you don't even see the results. So there's a lot of wasted blood and also wasted discarded tubes that should be drawn before you draw certain blood. So what? Somebody is looking from outside. They said, so what? I can transfuse these patients. We have blood and we can replace their anemia and blood loss. So I can wait until the last minute when I admit the patient to the hospital and just give them a unit of red blood cells to fix their anemia. I would respond to them. Blood transfusion does not have a very good outcome. It does not improve outcomes. We have to keep this in mind. We have to keep in mind that the allogenic blood is not the perfect substitute for the patient's own blood. There's tons of stuff happening to the blood during storage, and that's known as a storage region. That's including changes in the membrane and including the defects in delivering oxygen. In addition, you have to keep in mind that blood is an organ. It's a liquid organ. And when I do someone transfusion, it's not different from a transplant, an organ transplant. And that could cause a lot of stuff, including the TRIM and inflammatory, and plus also all the side effects we just talked about. Look at this here, electron microscopy shots of red blood cells. Even up to 12 days of storage, you start having some echonocytes in the unit. That's up to 12 days. If we get the unit was about 5 to 7 days to the hospital, so about several days after that, the unit has started having a lot of abnormal red blood cells, which is less elastic and less capable of moving in the capillary vessels. Wait until the end of the storage, about 40 days or so, you barely can see any normal cell in this the storage red blood cells. Not only this, we know that during storage we have a decreased 2,3-DPG, which cause high affinity to oxygen. What mean high affinity to oxygen? That means the red blood cells is going to bind to the oxygen and not leave it. It's not going to give it to the tissues. And this is very well known. And a lot of studies, they said, oh yeah, but once you transfuse, these red blood cells will regain this enzyme within several hours and then deliver the oxygen. We did a study to show that that does not happen. I think I gave this talk about a couple of years ago at the BMSS. And we did show that when we studied the changes in the SpO2, the peripheral capillary oxygen saturation, before and after the red blood cell transfusions, and we followed this for 24 hours. So this is where the transfusions happen and up to 24 hours. Yes, we did improve hemoglobin, which everybody is very happy about improving hemoglobin. I transfused the patients around 7, and now he's 8. I'm happy about this, but look at the SpO2. Even up to 24 hours, it did not improve. And that's taken from almost 70 patients. And we only included patients has no bleeding, no any procedures done, just regular patients waiting in the units, and just by fixing their hemoglobin. The goal was to fix hemoglobin. That's why our numbers are very low. And you can see the effect of on the SpO2. That means the oxygen is not delivered to the tissue. The SpO2 measuring the end oxygenation of the tissue, and it's not delivered here. Okay. Not only this, the PaO2 also. I forget to tell you over here. One of the reviewers said, "So what? The changes are not significant in the SpO2. I mean, it's, if you can look at this, 97 to 95, 96 is not that significant." Yes, it's not significant, but the goal for my transfusion is to improve this, not to make it less, okay? So that's really important point here. And look at the PaO2. PaO2 also reduced. And one of the reviewers said, when PaO2 reduced, that's good because that's mean no blood remained in the artery, but actually they went to the tissues. Yes, but we didn't see them in the tissue. So where are they? If they are not in the artery and they are not in the tissue, where are they? They are kept in the red blood cells. And that's what's mean the high affinity of red blood cells due to the drop in the 2,3-DPG. This data, I just got it yesterday. Last night, our statistician sent me this data. So just bear with me here because it's a little bit complicated. But what we looked at here is we measured the SpO2 before and after cell saver transfusion. So we did not include any allogenic blood here. It's auto collection of the cell saver of these patients. These patients are pediatric congenital cardiac surgical patients requiring cardiopulmonary bypass. And all of these patients are non-cyanotic heart diseases. And what she told me this, if we consider this is the time zero, this is where we gave them the cell saver product. So we checked the vitals before and after, and in this case it was SpO2. And she told me that there's a definitely increase in the lower SpO2 after the transfusion. Then we looked, I told her, I'm not understanding this, so can you send me a trend line? And that's what she told me there. She said, although it's not that significant in SpO2, but look at the PaO2. So the PaO2 also reduced here. Then we are testing another machines right now in the same study. It's called NIRS, which is near infrared spectrometry monitors, which is also measuring the oxygenation in the regional tissue and could be used as a somatic or as for the brain tissue. And for this one, we did notice that NIRS reduced after the transfusion of the cell saver product. And again, this cell saver is his own blood. The only good signs of this cell saver was in the cerebral nerves, which is measure the cerebral tissue oxygenation. And that was the only benefit, the only plus we saw in this study so far. We're still analyzing a lot of data. We're still analyzing a lot of other vitals. I'll definitely publish this data at some point. So let's get us to the point that we really need some management. We really need some patient's blood management. And that will bring us to the definition of our blood management. Everybody is aware of this definition. It's definitely to maintain the patient's own blood and avoid transfusion as much as possible. What's the difference between patient's blood management and bloodless surgery? They are similar in definitions. The only things we focus on the bloodless surgery is to optimize tissue oxygenation, to improve the tissue oxygenation in this patient's blood management. This study showing us different patient's blood management programs and different studies. And they did a meta-analysis of almost 17 studies involving close to 250,000 of surgical patients. And they found that almost 100,000 pre-patient's blood management and 135,000 post-patient blood management. And they noticed that patient's blood management definitely reduced transfusion rates by 39%. So almost 40% of the patients did not need transfusion, and that was significant comparing to these huge numbers. Almost 43% of red blood cell unit less, so close to a half unit less per patient during the study, and that was also significant. About half a day less length of stay in the hospital, and the complications were significantly different. And in addition, mortality rate was also significantly different. So there is a benefit of the patient blood management. Everybody is aware of this. And this is a meta-analysis, including 17 different studies. Now, another study by Hoffman, he focused on making the blood management the new normal. We should consider the new normal. The way he did this study, he sent the questionnaires to different people who implemented this patient's blood management. And the main question was, what could be the main drivers for the patient's blood management? Why did you initiated the patient's blood management at your center? And look at the responses here. Almost more than a quarter of them, they said patient's outcome, to improve patient's outcome. Others, they talk about the cost and versus blood shortages as well, and patient safety in addition to this. So there's a lot of patients focus goals here in addition to the cost saving. Hoffman also did another study to look at what about oncology patients. He focused on cancer patients in this study. And they noticed that there's three pillars in the patient's blood management in cancer patients. First, it's not that different from our normal patient's blood management, but at least managing coagulopathy. This is very important part here. We sometimes don't pay attention to this. Why? Because there's a triad in these patients. We notice that up to 60% of them coming anemic and iron deficient. And sometimes they deliver coagulopathy or they lose blood during multiple issues, as we discussed during the hospitalization, during the treatment, nutritional, a lot of other reasons for the cancer patients not to have, not to lose blood and develop the coagulopathy, which all of this, if it's not managed very well, it will lead to transfusion. And we know about all the complications of the transfusion, as we just mentioned. So what should we do here? They suggested in this study, and they supported by a lot of different studies in that paper, is try to manage the patient's anemia way in advance. Treat anemia way in advance. Treated with IV iron, treated with ERS, and the ERS was approved for the chemotherapy-induced anemia, so that's good to use in cancer patients. I know there's a speaker who's going to talk about this after me, and they'll also talk about the iron deficiency and iron replacement in these patients, and I'm going to also leave it for the speakers after that. So the only thing about this ERS is there is a study done in 2012 which found an evidence to increase risk of thrombotic events and short-term mortality in these patients. And this makes a lot of people hesitate. And that's why the ERA right now is only approved for chemotherapy-induced anemia. Minimizing blood loss. We did talk about this. How can we minimize this blood loss? What measurements we can do? So definitely there's a lot of issues we can do here. Use the ultrasound guided vascular catheterization, fine needle biopsy, flexible endoscopy. For surgery, prevent hypothermia. Utilize topical hemostatics or cell salvage, although cell salvage in cancer patients is not preferred, but you can still use it in some cases. Point of care testing in pediatric surgical and critical ill patients, you can use this. And in extracorporeal circulation, use different methods, which we are doing it right now here, and that's part of the study we are doing here right now, is miniaturized circuits, which make the circuits less smaller and take less blood, especially in pediatric patients. And definitely use not invasive procedures to monitor blood gases. Coagulopathy. Coagulopathy, we have to make this good attention to it. First, by laboratory testing. Viscoelastic testing is very important in coagulopathy, or detecting coagulopathy or the high risk for bleeding in these patients, and start using different treatment to manage this coagulopathy, from antifibrinolytics, DDAVP, which increases factor VIII and von Willebrand factor, and also improve, and we don't know a lot of this, it's improved the binding between von Willebrand and platelet, so that's improved platelet function. That's all can be done with DDAVP dose. Cryoprecipitate and fibrinogen concentrate, very important in coagulopathy. And in addition to the vitamin K, which, by the way, up to about 4 to 6 hours, if it's IV, can fix the iron in normal liver. In non-surgical, the strength catheter immobilization, minimizing the volume blood draws, and that's also can improve the anemia and maintain patient's blood, the patient's own blood. Now focusing on improving oxygenation. So ventilation should be with 100% oxygen, and try to aim for a higher VaO2. Use high positive index respiratory pressure, sedation if needed, and keep normal thermal for the patients. All of these could help with improvement of the oxygenation. Another study done by Frank et al., and he focused on the approaches to bloodless surgery in cancer patients or oncology patients. And the question they were asking in this study, in many instances where patients cannot accept transfusion because of some religious belief or personal reasons, or sometimes in our immunization, we have a lot of patients who receive a lot of transfusions to the point that we cannot find blood for them right now. So they were wondering in their paper if these same procedures, same cancer procedures and same cancer surgeries can be done for those patients who refuse blood or cannot take blood without any drop of blood. Why we cannot do this for everyone? And so they did emphasize on managing anemia way in advance. Start about several weeks before you admit the patients for the surgical procedure. And fix this anemia with either iron or with either ASA. Intra-op, they're focused on intra-op to use some meticulous surgical techniques, hemostatic agents, just like the previous paper that's they're talking about, normothermia, controlled hypertension, and also use the normothermic hemodilution. As we said, although it's controversial to use cell salvage in cancer surgery, but that could be assessed, and also liquid reduction filter may be improved the cell saver product. Post-op, full minimize phlebotomy, especially in the ICU units. Use smaller tubes if needed and less frequent to avoid the hospital-induced anemia. Another study they were done about stem cell patients, Jehovah's Witness stem cell recipient. And in this study, they found that 1 year survival between the people who went for an autologous stem cell transplant, bloodless versus non-bloodless. They found no differences, up to 88%. Were survived. A couple of cases happened due to death in this group due to different reasons, like either CNS hemorrhage or death due to sepsis. But they did not find any differences between both groups, and this is showing us here that bloodless or transfused autologous stem cell transplant show no differences in years of the outcome. And the way they focus here about the universal measures is to basically minimize phlebotomy. So we're seeing this in every single study. Every study is talking about how much blood we are using with phlebotomy. Providing vitamin K to improve coagulation factors, a lot of other in between, but I'm just highlighting the important one here. Iron for anemia. Try to seize the menses in female patients to avoid losing blood. Don't use NSAIDs or aspirin just to avoid any GI issues, and avoid antibiotic that could affect the bone marrow production, in addition to use the ASA. Anemia. So if somebody is already anemic, up to 10 grams, they said just use iron sulfate. Don't use anything else. Down to about 6 grams per deciliter, they used bed rest and oxygen, high size oxygen, up even down to 4 grams. Remember, all these patients are Jehovah's Witness patients, so they are refusing blood transfusion due to religious reasons. So that's why they are going that low, even down to 4 grams per deciliter. And in this case, it's just they suggested absolute bed rest and oxygen, a significant amount of oxygen. Now, thrombocytopenia, even not only the red blood cells, some of those Jehovah's Witness patients, they don't even take platelets. So we have also to focus on the platelets. And what they said is if you reach around 50, start with aminocarbonic acid or DTAVP. And also try to cease the vaginal bleeding in a female patient, and aminocarbonic acid once you reach very low numbers. So these are like down to 10 now. Suggested aminocarbonic acid plus some other vitamin K also suggested, and topical aminocarbonic acid if you reach down to 5,000 and there's any bleeding issues. This study focused on the safety of bloodless transplantation in patients with myeloma. And this is a retrospective case control study. Included patients who receive autologous stem cell transplant, bloodless versus non-bloodless, so transfusion versus no transfusion. It was done at Emory Hospital, and they included about 24 in bloodless and 70 in transfused group. And the median progression survival was 36 months and 44 was not different between both groups. And the median overall survival was up to 59 months, and it was not different in both groups. And that's what we are showing here. These were not that significantly different, up to 59 months. Again, their focus was very close to all of the other studies: erythropoietin, iron, vitamin K, tried prophylaxis of GI bleed, avoid aspirin, avoid NSAIDs, estrogen in women to avoid menstrual periods, and also folic acid to help to support with the own blood. Now, in summary, blood transfusion is not without risk. In many cases, it's better do nothing rather than intervening and potentially causing harm by blood transfusion. Keep in mind that blood is not safe. Blood procedure is just like any other procedure in the hospital. Anemia is a condition that is both treatable and preventable. So try with your patients that as long as you know that you have a procedure coming in the next few weeks, start management in the 4 to 5 weeks before that. Careful planning to how to optimize the patient's blood health and improve outcome without transfusion. The care should be minimize blood as much as needed, and every single drop counts of the patient's own blood. It's very valuable. Allogenic blood is not the perfect substitute for patients' own blood, and we have to always think about the unit that you're going to transfuse to this patient is kind of an organ transplant and could have as high risk as an organ transplant procedure. Clinical studies show that well-delivered bloodless care can result in similar or better outcomes in patients who refuse blood products compared to those who we transfuse, as we saw in multiple studies. And this is my acknowledgement for some people who work with me in my lab or through the hospital and also from the transfusion unit. And I'll stop here. Thank you.